who deserves invasive prenatal diagnosis. And for this, I would like to welcome our moderators. Both of them are very well-known senior consultants and probably need no introduction to this audience, but it is my privilege to introduce them. Dr. Raju Sahitya sir, an absolute authority in fetal medicine. He's the convener of this program and he's been doing such programs all across the country. He is practicing at Pushpa Nursing Home and various hospitals across the city. He has been the past president of AFG and ISPAT. Welcome, sir. And we'd like to welcome our co-moderator, Dr. Manohar Motwani, sir. He is an inspiration for all juniors and someone who leads by example. He is the director of Karbhari Nursing Home and the past president of AFG and secretary of SOFC Maharashtra chapter. Now I would like to welcome our expert panelists. We've heard them today. I would like to call them all the queens of fetal medicine. Dr. Purnima Satoskar, Dr. Vandana Bansal, Dr. Bela Bhatt ma'am. Please join us for the panel. Thank you. I would like to welcome now Dr. Kartik K. Bhagat sir. Sir is a senior consultant at Grace Maternity Hospital, founder, member and past president and currently the trustee of AFG. Dr. Jayanti Kamath madam. She is a consultant at Shrishti Fertility Care Center and a women's hospital, Andheri, and Dr. Kamath's Hospital, Jogeshwari East. She is the secretary of AFG. And Dr. Rupali Dharwadkar. She is the convener of today's program and she is a consultant at Surya Hospital and other prominent hospitals in Andheri. She is a managing committee member of AFG. And once again, I welcome all of you and I hand over to the moderators. Thank you. Madam, there. Ma'am, sit now.
हम लोग उसे राइट और लेफ्ट देखने का है नहीं आते तो राइट लेफ्ट देखने का Good afternoon everybody. Well, we welcome you all to this much awaited panel discussion on who deserves prenatal invasive screening. Well, let me start by first congratulating my co-moderator Dr. Raju Sahitya for he's the brain behind this program. Believe me, the entire program format has been done. He's a humble cat. He'll say that, well, I have not done it. Everybody has done it, as always. But he's put in his effort. Now, he's got two loves in his life. The first one, of course, is his wife. And the second one is fetal medicine. Right? So that's how it is. So he's put all the effort and we all, the other side of Dr. Raju Sahitya, the one which is given here. I know him from much, much earlier when I was his house surgeon at Vade Hospital. From that time, his training has been all into that. He had a lot of legendary gurus. All that has been inculcated down the line. Now, he's become a pioneer on invasive testing. You must have heard about him having workshops all across the country. I mean, I won't take more time, but it's important for you to know. He loves his mannequins. They are so beautiful. Right? So he's been testing on them, training them across. I think he's gone international too. Even I think you had this thing in Nepal also. What a little do I gather from. Of course, our digital media gives us all. So now coming to the topic proper, well, a lot of it has been taken over in the talks. Now you must have seen those three beautiful talks by three fantastic teachers. Right? You must have seen the amount of effort they put into their teaching. So I think Dr. Purnima has already been introduced. Well, let me tell you, she is a treat to listen to. A little amount of sample. You must have got people who have not heard her. You must have heard her during a lot of webinars also. Vandana Bansal was always a treat to listen because she's so clear with the concepts. And of course, Bela Bhatt, our very own. Now this girl, I have seen her catapulting in the last 5-7 years from what to what. She was something we entered into AFG and now she's catapulted in such a big position. She loves the fetal medicine. You've seen the amount of practice she has with the cases. And we have our own local gynecologists. So 3 plus 3, we have the 3 experts and the 3, let me put as semi-experts. Should I put it that way? Okay. So the questions are going to be put across. So if you don't know right and left or to your right or to your left, you can take over. So anyway, I think I'll go on to my dear friend Raju to start the innings. I'm just going to be a parallel assistant to him anyway.
We are going to do it together. I would define you better. The ball is bowled by the obstetricians. So you are very important, not by chance. I'm referring to this panel and we have designed this panel in such a way. We have 3 busy, sincere obstetricians here And we have three excellent, young, talented, experienced, senior fetal medicine people here. So, you heard these talks and most of the journey has been covered. But now let's come down to practice. When we are in our chamber, where we are seeing the patients, we have to understand what is to be done. So in this modern era, with this paradigm shift of non-invasive prenatal screening, it is screening, not diagnosis, it is screening. Then what happens next is, if they are reported high risk, always use the word high risk and low risk. Don't use the word positive, negative. If you're saying positive means you already got a diagnosis. If you're saying negative, already you got a diagnosis. No, they are at high risk. What high risk? Higher risk than the background risk. And then you have to scratch your head and see what next. So tell us all this. We have our expert panelists. I already told you 3 obstetricians and 3 fetal medicine persons. And let's start the first over. With the high sensitivity of a combined test and NIPS, what still warrants moving to invasive diagnosis? So I will ask Dr. Karthik Bhargat, our obstetrician, what makes him do this in his practice after doing screening?
See, basically you want a diagnosis. You want to know whether the baby is normal or not. And the implications are bad, because if it turns out to be an abnormal baby, then you would offer a termination. Because the implications are bad, you need to come to a diagnosis. And how would you know whether the baby is normal or not? So that's the reason you would want an invasive test, which gives you a definite answer, yes or no.
Yes, Jayanti, when would you think about? Why would you think in this era for invasive test?
So combined test is actually only a screening test. It's not a definitive test. So if there are indications like hereditary disorders or single gene defects, we need to do, or an index case, as Dr. Pela mentioned, we'll need to do a CVS.
Yes, Rupali, when would you think of this? Why it warrants you to do this?
I would consider doing a CVS or an amnio in spite of the fact that a combined test comes normal, in case the NIPS comes as a high risk, or if she has a previous baby who's a, if she, the
Mike, please.
or if the parents are having some, some abnormal genetic problems, then these are the reasons where I would think of doing a CVS or an amnio in spite of the fact that her combined test is a normal test. Because after all, we have to remember that it's not 100%, and that is always a probability which we give the patients.
So very well said. Like you heard, combined test and NIPS are only screening test. They only tell you high risk or low risk. And invasive testing is a diagnostic test which the patient wants to know, you want to know. So this is the sum up of all the reasons why you would do invasive prenatal diagnostic testing. Like already mentioned about combined and NIPS, structural defects, any history, ART conceptions, they have a high probability for aneuploidy. Because first about the demographic, the age and all, then the lab manipulation, the hormonal manipulation, all this matters, and it is going to take a toll on the fetus, and there will be a problem. Yeah, anything Anurag you want to say? No, we are going to discuss. But
if you're normally when you do non-invasive test, I mean, especially only for ART.
We'll define it differently, because they are having a demographic problem. Age, infertility patients are usually older by the fact that they have higher risk for aneuploidy. Then the lab manipulation, hormonal manipulation, all that matters. Therefore, why do IVF pregnancies have more miscarriages?
Can I have a word here? So what we typically do is we do offer them screening test, maybe a higher sensitive screening test like NIPS along with your combined test, and then if they turn out to be high risk, definitely invasive. Not straightforward if there is no high risk factor other than just ART pregnancy. We can offer screening test, and we do offer
What,
I
Dr.
think-
Purnima, would you like to add?
The ultrasound is the most important test which we have to do. So if the ultrasound is really normal, then we are reassured. Then of course you can do either a double marker or an NIPS. But if there is something on the ultrasound, then you need to test them.
Yeah,
Even
Vandana,
if
what you,
it's, yeah.
Vandana, what
Raju,
you would like to say?
I think ART basically becomes a high-risk group as far as abnormalities are concerned. But that doesn't necessarily mean that all these babies will be abnormal. So because they fall into the high-risk group, you would offer them all the tests more diligently. And you would follow the same protocols. So ultrasound,
So
dual
only
markers,
ART
NIPT,
is not
only
the reason for
What I was
an
discussing with sir is ART conception with one or two high risk factors that should be added. So it is not a blanket statement. That's what
No,
I
no,
mean.
yeah.
ART
We
can
are
only
not
be a
yet
screening.
completed this discussion. We have not yet completed this discussion.
Then suppose
Yeah,
even if
Vandana.
Controversial ART conception.
even if I put
ART
an example to it,
conception
ki
itself cannot be a reason
a
for
patient with
invasive.
ART conception, she is diabetic, she is 40 plus.
Then
Still
also,
then
they
also
are at
screening
higher
it will
risk
be
for
the-
So it is very clear, that is why it is being put.
No,
So
you
the
know why the
message should
sentence
go.
is there to make sure everybody is awake.
I am at least awake.
and see, for ART patients, it's a high risk, it's a precious pregnancy already. Why would you offer them an invasive test and increase that
Unless
risk?
indicated.
You have to give them a high sensitivity screening test, followed by, if required, invasive
What
test.
about these elderly patients?
Karthik, all pregnancies are precious.
What
Let me
about
tell
this
you.
elderly age? What elder age is elderly age, according to you people? So 35 and more, you should go for invasive testing? No. So that's what I'm saying here. We have put up here elderly patient. Correct. Correct. So that is how it goes.
That
So
is why
these are some
panel,
of them are question
that
marks.
is why panel and the resolution, what is going to come from discussion. That is what is panel for.
So I hope you are going to change it later
No,
on.
no, I'm not going to change it. This is the message to be given.
We are stuck at the Strait of Hormuz. Let's move on.
Okay, now let's have a case study. The low risk routine scan is there and the patient is 28-year-old, a priming gravida, and her NIPS is low risk. So the scenario is 20 weeks anatomy scan shows a ventricular septal defect and a thickened nuchal fold. What next? Yeah,
There-
Bela?
Yes, there is a rule of thumb. Whenever there is any structural defect in the fetus, we have to offer invasive testing. And as we begin with the fish, which is a quick aneuploidy test, and then if it turns out to be positive karyotype, otherwise
Anything
microarray.
else you have to say, Purnima, about this?
Chromosomal microarray and DNA storage. If chromosomal microarray is normal, then we may think of going ahead
Yeah,
and doing
Vandana?
whole exome.
Similar only.
So the panelists, their action is offer an invasive test and carry out microarray analysis to check the microdeletion and microduplication despite there is low risk NIPS. Now, talking about CVS and amniocentesis, terms and conditions which are there. Vandana, could you tell us now, when would you say CVS and when would you say amniocentesis?
If the screen is positive in the first trimester, whether it's an increased NT or the dual marker first trimester screen is positive, we will do a CVS. If we have a previous child which is affected and we have the genetic mutation already there, then a CVS is better. For things like thalassemia, where we've screened and it comes out as carrier, the recurrence risk is going to be 25%. All for them, CVS is a better test. Amnios we will do when there is a quadruple which is positive, or a structural abnormality we are seeing, or a soft marker which is very strong enough, then amniocentesis. So it is more on the timing. If we need to do a test in the first trimester, it is 11 to 14 weeks, we do CVS. If it is after 15 weeks, we do an amnio. For what madam said, madam has said DNA to be saved for your last case. Microarray may still come normal because your NIPT is okay, downs may not be there. There must be some single gene which will not come in the microarray. So when madam said DNA to save is for that only, ki if microarray comes normal, then I still have that sample to do a whole exome on that.
Anything else to add, or this is what is the resolution.
It's covered everything. Again, we already said if there's a mosaicism, then we may want to do amniocentesis.
So early decision making, a 36-year-old gravida 2 para
Sir,
1.
can we go back to the first slide, part 2? No, the question pertains to what we were discussing is she is a 20 weeker with a VSD with a thick nuchal fold thickness. Why we offered her NIPS?
No, she has done NIPS before and then the VSD was picked up.
No, it's already reported low
The
risk.
history.
Okay.
VSD was picked up on anomaly scan.
This is an anatomy scan which was done, and there these defects were picked up. The structural defect like the...
That's
Yeah.
possible because NIPS will give you is a good sensitivity only for mainly trisomy 21, 18, 13. And there can be some other genetic condition like 22q11 also with VSD and all. So that's the reason the NIPS EPS was low risk. Maybe like IVF conception, they wanted NIPS for screening test. Many people do NIPS
This
these
is
days.
trying to tell you an NIPS is low risk. But when you get a structural defect, what next? We are discussing when.
Sometimes the patient may come immediately after 14 weeks. She's come at 15 weeks. You miss the dual marker test.
And now a lot of patients are asking for an NIPS. So you do a good NT and they say, no, I don't want an FTS, I want an NIPS. So at that time, you can ask for an NIPS.
So then you will, when you have a situation like this, you will go in for invasive prenatal diagnosis in spite of NIPS being low risk. So a need for AFP is there. Here we have a patient who's 34-year-old, previously delivered a child with spina bifida. The scenario is 16 weeks pregnant. Your choice of invasive prenatal diagnosis. Vandana?
I will not do an invasive testing. Spine, you can see on an anomaly scan. Even in the first trimester, spine can be seen. At 16 weeks also it can be seen. So you will do a good scan even at 16 as an early anomaly and will repeat it at 18, 19 weeks. But for spinal defect, I will not do an amniocentesis.
Okay, even if...
Earlier we used to do amniotic fluid AFP,
Yeah, for AFP. So
for
this is...
screen, for kind of a diagnostic test, because that time ultrasounds were not so good. Now the ultrasounds are excellent, and if I have done a scan and the spine looks normal, I will reassure her that no amnio, we will do another good scan at 18, 19 again, and if it is also normal, no amnio.
So this is what the difference is, that ultrasound scanning has improved like anything. You know, we have good resolution, we have good diagnosis, but earlier there used to be a need for AFP. And then it was not CVS, it was amniocentesis which should be offered if you need to do the AFP. Otherwise, currently, like experts like Vandana, Purnima, Bela and all, likewise, they can make a good diagnosis on ultrasound.
So just one comment on, if suppose the patient has already come with a quadruple marker report which is showing high AFP, because recently I got a referral for amniocentesis because the quadruple marker was showing high AFP. So one message here is, when the AFP is high, we need to rule out, as Dr. Vandana Vansal mentioned, the spinal anomaly or abdominal anomaly to, rule out whether it is there or not. But amniocentesis is not indicated for high AFP. Amniocentesis is indicated for low AFP with high beta HCG and inhibin A, where chances of Down syndrome would be there. But high AFP is not an indication
So
for
this is a very good point made. This is a very good point.
High AFP means look for spine, look for placental disease. So these high AFPs will have IUGR later on. So no amnio for a quadruple showing only AFP high, because that they write on that high risk for neural tube defect. It is high risk because AFP is high. So do a good scan to see the spine. If it is normal, do a Doppler to see that there is no IUGR. If there is no IUGR, the placenta is normal and the spine is normal, no amnio even with an AFP high, as what Bela said.
Very good point.
What are the chances that spina bifida could have a genetic basis as well, or a genetic association? So would amniocentesis and a genetic test not be warranted? We said that normally 6% of all the babies would be abnormal. So if you have, the thumb rule is that if there is a structural defect, you would want to rule out a genetic basis. So would it not apply here?
So recently they are looking at certain genes which may be involved, but as such over the years, unless there is another anomaly along with it, you usually don't find anything.
So this is increased risk for a neural tube defect. This baby doesn't have a neural tube defect. So here though we will not do, we will just scan and see. But what you said, sir, is right, that any structural abnormalities nowadays we start doing amnio for a single gene disorder. So neural tube defect also, but the chance of getting an abnormality is very, very less. So usually what we say is, if I get the second baby also a neural tube defect, then I want to do a genetic test. But yes, some patient would say, yes, I still want to do.
And just one addition here, that in one of the neural tube defect is encephalocele also. If there is occipital encephalocele, then for Meckel-Gruber, you would like to do, invasive testing and try and rule out with kidney renal abnormality and polydactyly and encephalocele. Yes, there would be, it is worth doing amniocentesis and rule out Meckel-Gruber syndrome.
Encephalocele, lots of disorders, hundreds of syndromes with encephalocele. For encephalocele, 100% amniocentesis.
The other thing is
that is multiple defects in the fetus, not isolated spina bifida.
No, many of these patients may terminate their pregnancy, and you can send the products for testing afterwards. Whenever they are terminating, I always send it afterwards. I don't do the procedure. In the good old days, we used to be worried that the culture will not grow. Now that is gone, because we do CMA and we do WS. Because when we send that, what happens, we send fish, we send CMA, and I've seen these patients, they suffer so much. The fish report comes normal, then the CMA comes normal, and they start becoming hopeful. And then in the end, then they have to terminate. Again, we counsel them that this is not going to be a good baby, and then that whole journey for them and the expenditure is too much.
So counseling is the key. Counseling is the key.
You can send it afterwards. You should send it. It's kinder to the patient, I feel, to send it afterwards.
What is the chance of you advising for such minor sonography thing, the invasive test? These, like major you said ventriculomegaly, and you said that you should go for the invasive. But these are also structural defect, and if they are in combination, so is there any criteria to decide when will you advise the invasive in such patients?
So soft markers which are significant are the ones where the likelihood ratio is high. So they are ventriculomegaly itself is a marker, but it can be a brain disorder also. So that is a marker, but it has got lots of other implications. So that nasal bone absent or hypoplastic, whether it is hypoplastic, absent, unossified, one side, two side, all of them are implication is absent nasal bone, likelihood ratio 6. Ventriculomegaly 5 to 6. Third is your nuchal fold thickness. Sir just showed one. Nuchal fold itself is a high likelihood 3.5. So these three, and ARSA again one where we would also think of 22q deletion. So these are 4 strong markers where the likelihood ratio is significant enough that even if your FTS is normal, this will multiply with 3 and 4 times and it will come high. So these 4 are required. CP cyst, pelvic tests, echogenic focus, not important.
Vandana, I wanted to know what is ARSA.
So aberrant right subclavian artery. So normally during our echo or our, sorry sir, aberrant.
So resolution for this point is that, Anurag.
No, sir. Sir, you are sitting for that only to pick up wherever we say wrong.
So the clinical resolution is, like what has been pointed out, just for spina bifida, ultrasound is a good modality, but where there are other markers, which like Dr. Karthik said, what if these things are there? I think then amniocentesis is what is the rule, and you can also do the AFP. It's not that you need not do that once you're doing amniocentesis, because you get an opportunity to even go through that.
Now the question is, you have a marker test which is negative, you have a dual marker which is negative, or an NIPT which is negative, and you have a 1, 2 or 3 soft markers. So would these people qualify for a genetic test? A normal first trimester screen
negative,
that is dual marker or an NIPT which is negative, and your sonogram shows a few 1, 2 or 3 soft markers, need not be all these. So would that baby qualify for a genetic test?
More than one soft marker, yes. Because although they say, for example, if they say ecogenic bright spot is to be ignored, there are some studies which say that in Asian women it is little more significant than Caucasian. So by itself one would never do, but if you had two markers, probably I would go ahead and do amniocentesis.
So it becomes NT for the first trimester, nuchal fold for the second trimester, right?
No, no, no. There is a nuchal translucence in first trimester, there is nuchal fold thickness in...
Exactly. So people should not confuse between the two.
And these are two independent markers.
So more
nuchal
than the
translucency of first.
Centile you take or 99 centile you take. When you come to NT, when you come to NT and CRL, do the 95th centile as the cutoff or the 99th?
So depending upon what centile it is, the chances of genetic causes would be different. 95th to 99, little lesser, but more than 99 centile, very high chances. You'll have either some structural defect or some genetic syndrome. Some cause has to be there. So depending upon the increased thickness,
so the cutoff
of
3 to 3.5 NT and more than 6 millimeters nuchal fold should give an alarm signal to you?
So it's a very relevant question. When the nuchal fold thickness, nuchal translucency in first trimester between 95 to 99 centile, 7% will be aneuploid, but 93% will still be euploid. Whereas when the nuchal translucency in first trimester is more than 99 centile, that is more than 3.5 cutoff for any CRL, there also 30% are affected, but 70% fetuses are still will have normal, live, healthy birth. And that's the reason we say that we must not terminate just based on 6 millimeter abnormal and terminate. No.
So that means
work up because 70% would still be normal.
So a lot of false positives, right?
Yes,
Not
but
false
you
positive.
need to do
So you may have a
normal
high, you may have a
variations.
more than 3.5 NT but having a normal fetus, isn't
So
it?
you look at the structural defects rule out,
Right, so that's
genetic
what it comes
cause
down
rule
to.
out.
Patient telling 3.5 tera watt lag gaya is something we can keep
no,
away,
exactly.
right?
That is the message.
Okay.
Yeah.
All said and
it's
done.
important to do a good 2D echo. And in some of them you may find single gene defects. So you have to look for the single gene.
Gotcha. So Karthik, your Bhagavad being a moderator has not gone, right? Good.
Anyway, I'm
Now
on
you're
the wrong
other
place.
side.
I'm
You're
on the
other
wrong
side.
side
Yeah,
anyway.
you're on the wrong side. So let's
All
go to
the
the
time.
next question. Some lighter time in life I think is worth it. AFG is known for all this talk, right? It's not very formal. All of us are very informal out here. Anyway, take the next question. Now we all know NIPS takes 5 things. You're 21, 18, 13 and X and Y linked, right? Now this is a patient who has got a high risk NIPS for a sex chromosome abnormality 47 XXX called the XXX syndrome. Does this patient deserve an invasive test if they are certain they will not terminate? So if your patient has got a XXX syndrome, would you like to do an invasive test in these patients?
So you give the answer.
Really? So you got a change of, you say yes, you say no, you say yes? Yeah. How good are these XXX ladies? How are they like? Are they normal? Are they abnormal? Or we look at them, you can tell them she's XXX, she's XX?
NIPS for these 47XX and for a sex chromosome problems, NIPS wouldn't be really a good positive predictive value is
No,
very
we are talking
relatively
about-
low.
Okay.
That's the reason why I would like to have a diagnostic accuracy to proceed and then do the counseling for the patient if they still want to keep it. This would be one of the reasons why I would think of doing an
Keep it, but
invasive.
these ladies are almost normal, right? They may have a little learning disability. They are as such very pretty to look at, long legs they have, and they have got a, they
They are
they are
super
fertile.
women.
They are fertile.
Super women.
So these girls are almost normal,
But
right?
why not have a
Genetically.
diagnostic accuracy to be better planned,
Yes,
do
you
a
are-
better
you-
counseling?
You have a change of action.
So, as patient is categorically told that whether it is 47XXX or whatever it is, we are not going to terminate this pregnancy and they don't want the diagnosis in hand, then they have an option of opting out of amniocentesis.
It's not compulsory.
Because we know that this is not a disorder which is going to affect the baby. A baby will have a
they are
normal,
fertile,
healthy
they are
life
normally
and they don't
sexually
want to
active,
know
yeah.
about it. And
Yeah,
in
one-
fact, there are so many females who wouldn't know that they are 47XXX.
Perfect, yeah.
So this is a very apt question now because NIPS में ये बहुत आ रहा है. So because otherwise screening FTS we would never get this on a screening test. This is only on NIPS we get lot of these XXX and XXY and XYY on our NIPS report. We've done lot of, one is don't do a CVS, do an amniocentesis for confirmation of this. You said the ladies are pretty little subnormal.
Yeah.
Who wants a subnormal child? How will you prove that this triple X? One second.
The men want. Beautiful and slightly dumb.
Slightly down.
Men want a wife to be like this. Men don't want their child to be like this.
Nobody wants. But
Nobody wants
if
a
they
subnormal.
if they get to see somebody, they will like it.
Sir, serious.
I think it is a different thing.
But sir, men never
Sir-
get what they want.
Sir, serious. Now coming to a serious note,
Serious idea.
I have published 4 triple X cases. It is published in a Vadia journal this month only, of 4 babies with triple X. Amniocentesis done on an NIPS. Amnio came as positive and it came out as triple X. All of them were triple X. We counseled all of them that they are going to be good. There is no problem. These babies you would not have picked it up had an NIPS not been done. And they are now, and one of them was the mother herself. So the mother was also triple X. The pregnant women was triple X. Then also we counseled that you are normal, why your child should not be normal also. And 4 more. It is published. You can see it in Vadia journal, this month's report. All 4 of them terminated, because if you write subnormal in that report, then nobody wants to have a mental retarded baby.
Exactly. So the point here is they have categorically told that we are not going to terminate if it's going to be turned out. That's the reason we are in this particular case we cannot.
Yeah, Karthik.
Let's go a little backwards. I have a problem with the question itself. Why do you say, and if they are not certain, they will not terminate? Why would I not terminate? Why should I not be given a choice? Any abnormal baby, why would I not be given a choice to terminate?
No, for religious
Whether it's a
reasons.
male or a
Religious
female.
reasons. I have so many patients for
doesn't want to
religious
terminate.
reasons. Obvious anomalies there, they don't want to terminate.
But confirmation then also required.
This is, NIPS is a screening test. We have to register that. There is a diagnosis required before you do any termination. We have to believe that. Sometimes, therefore, I repeatedly say, don't say NIPS positive. If you have NIPS positive, then why you should do a diagnostic test? You have to understand this is high risk, and you just tell somebody, they will not accept it. Let that lady look beautiful and superwoman and all. They will not accept when there is a aneuploidy reported like this. So they need a diagnosis. They need an answer from you. Right? So this becomes a clinical utility.
That means bottom line is do it.
It becomes a clinical utility. Yes.
What are the chances of a baby getting 46 triple X when mother is 46 triple X? Anybody has done a study on that?
It's very rare. I had only that one patient who had a previous baby abnormal, so we did amnio for this time and it came as triple X. So because previous baby abnormal, this time triple X, don't know why the geneticist asked for parental karyotype, and the mother also had triple X. So very, very rare. There's no studies on this, but yes, rare.
We have 17 minutes to go and 17 plus slides to go.
Now we have got this thing about on demand. We have LSCSs on demand. Now we have a patient who says that I demand an invasive test, even if my ultrasound and screening tests are completely low risk. Yes or no?
Purnima.
In other words, she says,
Purnima,
I
what do you
want
have to
do
say?
it.
It's not very common, but I had during COVID, I had a patient who had come from abroad, and she was 42 or something like that. So when we gave her the risks, she said that I would straight away like to go for a diagnostic test. So I did a CVS on her and it was normal. But that was because they were Googling and they were very educated. But I don't think our Indian patients yet are demanding it.
Oh, great.
But even if they demand, I think you should offer it to them, provided they understand the risk.
Yeah, so you have to put
involved
across
and the
the risk.
possibility
That point is
the
very,
report
very
may not
important.
be clear.
And
Accept
even
the
the
risk and do
ACOG
it.
guidelines.
Yeah, so according to the ACOG guidelines, they allow for testing. The burden of proof is on the physician to inform them of the 0.5% fetal risk. So here we must ensure they understand the difference between screening and diagnostic testing. So the point well taken, tell them this is what can happen. You want to do it, we do it. If you don't want it, we don't do it.
There are a few studies where they have done it in everybody.
Okay.
There are such studies.
Who deserves special management during these procedures? No, 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 no. No, I think this has been tackled. RS negative mothers, when we do this CVS and this thing, we take anti-D 300. I think this has been taken care in the lecture itself. And amniocentesis carries a lesser risk of the sensitization. So that is where, and even you already said that twins have got a higher rate of losses as compared to singletons. So CVS with specific procedural expertise, procures counseling, special medicine, vanishing twins. Okay. Now to summarize, we all know that it's CVS versus amnio, and we have got to have reasons for doing it. Structural anomalies becomes a straight go-ahead for invasive testing, and parental informed choice says invasive remains a vital diagnostic tool that, when performed by experts, offers definitive answers but must not be used loosely.
So now we go to the rapid fire round. Okay. So defining the baseline threshold for invasive. Question 1. Clinically speaking, you automatically deserve or meet the criteria for invasive prenatal diagnosis rather than the routine non-invasive screening. Which are the conditions where obviously invasive has to be done, and there is even absolutely no need for doing a non-invasive screening?
Yeah. Parents are carriers for single gene disorder, commonly thalassemia, SMA. Yeah, previous child affected. But again, they have to be carriers.
So here it is summarized for you. Let's go to the next. Case example, the first line dilemma. The scenario is a 26-year-old primigravida at 11 weeks gestation with no family history of genetic disorder, and she's request immediate CVS. She does not want an NIPS or the combined test of the first trimester screening. She says she wants 100% certainty. I want 100% guarantee that everything is going to be all right. The discussion to the panel is, does a patient with low baseline risk deserve an invasive procedure when non-invasive screens are available? Yes, Bela is ready.
So first, there are two aspects of it. Number one, counseling is very, very important, that we have very good screening tests, these are it, and with the sensitivity rate. Second aspect of it, she says 100% certainty from day one. There is nothing like 100%. Even if you do invasive testing, you have to tell that this test can detect karyotype, then microarray, then whole exome. Even whole exome sequencing cannot rule out all genetic disorders. So that has to be made very clear. So here the counseling becomes very, very important. Despite and understanding everything, if she wants, that's a different issue, but then there won't be 100% guarantee.
Purnima, you want to say anything? Vandana?
I'll send such patients to you. I won't do it.
You will send?
I will send them to you.
You give a referral note properly, huh? So that I know what you want. Okay. So CVS versus amniocentesis, managing the gestational windows. Already we have done this, but to emphasize on the audience, how does the gestational age of the pregnancy alter who qualifies CVS versus amniocentesis? If you would just sum up with a pointer, each one of you.
So earlier, as we said, in the combined test, if you find high risk, or NIPS, if you find high risk in the early pregnancy, 11 to 14 weeks window, then that we have CVS, which is available, early diagnosis. And if we have some marker of the second trimester, maybe quadruple marker, or on anomaly scan, we find a structural defect or some soft markers, major markers, then yes, because it is 16 weeks and beyond, we would offer amniocentesis.
Yeah, Purnima, anything? So, you have to remember that what all said and done, don't do a CVS before 10 weeks, because this results into vascular insult. And like our learned speakers told in the morning, that it can cause limb reduction because of the vascular insult. And don't do an amniocentesis before 15 weeks. Risk for miscarriage is high. Again, abnormalities are also known. Early amniocentesis came into picture is when CVS was not there. So in the greed of early diagnosis at 14 weeks, also amniocentesis was done, but there were problems. So now not required. If early diagnosis is required, it is CVS, and if the patient reports late in pregnancy, obviously it is amniocentesis. So ethical allocation and false positive. This is something which keeps on bothering us. We do all the report, we do all the counseling, we also mention it to the patient about the false positive possibility. But when the report comes that way, question is, with the rise of cell-free DNA screening, we see false positives due to confined placental mosaicism. Who deserves an invasive test and when NIPS contradicts ultrasound findings? Purnima, would you highlight on this?
First of all, if there are ultrasound findings, most of the times we would do an invasive. Secondly, if there is something which is coming which is false positive, we have to confirm it by doing invasive tests. We cannot sit quiet and say this must be false positive. So it has to be confirmed.
So when it comes as a false positive, which test would you prefer, CVS or amniocentesis?
NIPS comes. Then it has to be amniocentesis. Yes.
And the reasons, if you could give to the gathering?
Because in NIPS, the cells are coming not from the fetus but from the placenta. So if there is confined mosaicism in the placenta, they may be reflecting in the NIPS report. And the only way to confirm this is by taking sample of fetal cells which are in the amniotic fluid by doing amniocentesis.
That's a very correct answer, because you don't have to contaminate. There should be no maternal contamination. So amniocentesis is very close to that. Whereas CVS is not going to be, it may also give you a mosaicism result, and then there will be a burden of dual invasive testing. You have an NIPS which is showing a mosaicism or false positive, and then you do a CVS, again you get the same thing. It is possible to that to happen. Therefore, you should tell her to wait until 15 weeks. After that, you should do an amniocentesis.
Now, one thing I want to ask you about is NIPS. We are talking so much about it, right? Now, it started with a good amount of money cost. Now, the cost has come down tremendously. Do lab parameters or labs make a difference to the sensitivity and specificity of NIPS? Are the standardization there? Because I'll tell you a simple thing. A patient of mine, 35-year-old, went for an IVF. As she realized she got pregnant on her own. So we sent her all the things. She was about 34, 35, I think. So we sent her for, her NT scan was normal. And we sent her for a dual marker combined screening. It came to be high risk. We sent her for NIPS. Everything was okay. She said, okay, I'll have an NIPS. It showed high risk for 13, 18, 21, all three. I said 17 weeks we did an amnio. Believe me, the amnio CMA was normal. So when it comes to these false positives of NIPS, where do we hold? What is the specificity of NIPS really? How many false positives do you get? Books say 99% plus. That means 1 out of 100 is going to be false positive, right? That means out of 100 amnios you do or 100 chorions you do, 1 is only going to be false positive. 99 are going to be positive.
So in NIPS, one thing is very important. When NIPS was introduced 10 years back, we used to do mainly in high-risk patients.
Correct.
Now for a positive predictive rate of a test, if the prevalence of a condition is higher in the population, you will get better positive predictive rate. That means lesser false positive.
Correct.
Nowadays what we are doing it, we have generalized, we are doing even in low risk population, intermediate. So when the population doesn't have prevalence of that particular condition high, you are going to get more false positives. That is particular for any test. So that's the reason NIPS sensitivity. Sensitivity is different from the detection, the positive predictive value of a test, because true positive from the positives that you got is what is the positive predictive value, and that is different. And therefore, if we use NIPS as a secondary screening test, combined test, high risk, then you offer, then you'll get better detection rate rather than offering it to all. You'll have lesser false positive.
Do you recommend after doing a combined test, NIPS to a patient?
Of course.
Or
sir,
would you like to a high risk, speak about invasive prenatal diagnosis?
So we always give option in high risk. Of course, first option would be invasive test. Sorry?
I meant to say, can you do multiple screening tests? You do a combined
There's no
test.
point. No. What we are talking about here is, when there is high risk, first I would offer diagnostic test. There are patients who do not want to go for CVS at 14 weeks. There we have an option, a secondary screening test with a higher sensitivity for trisomy 21, 18, 30.
That is possible. Yeah.
So that is one option which is open. And in intermediate risk, again, we can offer an IPS, because by the time we reach 16 weeks, a time for amnio, before that we have the report of NIPS in hand. If they are high risk, then we would offer. We will have a look at the embryo, the fetus also again at 16 weeks, and then we'll take a call for amnio.
So one more thing, NIPS is 99.5%. For trisomy 21 only. For 13 and 18, it is not 99%. It is less than 95%.
You talk about sensitivity, right?
Sensitivity.
But the specificity is almost the same. Almost the same for
yeah,
3.
but for all of them, specificity is low. So sensitivity is good for trisomy 21. We have labs which say basic NIPS, enhanced NIPS,
Correct.
advanced NIPS. So what is this is, basic is 13, 18, 21 XY.
Got
For what it has been standardized. For 1, 2, 3, 4, 21 chromosomes and 22, it doesn't have a validation. And one more enhanced is looking at the segments, copy number variation, 22Q and all of them. Of all of them, only 22Q has a validation, all others don't have. We get lots of report of 1Q, 1P, 16P, 7P in our NIPS report. All of them have come normal on amniocentesis. So no enhanced has no validation. It is only for trisomy 21 only. So if you are doing a screening, do only tell the patient it is for trisomy 21, okay for 13, 18 and XY. Not for all the chromosomes.
This is a very important take home, because we say that NIPS is more sensitive compared to combined testing. It is relating only to
21.
chromosome number trisomy 21 and Down syndrome.
And we send for basic, the lab says enhance करते मैडम ज़्यादा पैसा ज़्यादा कोई बात नहीं कर लेंगे ज़्यादा फिर वो आता है 1P. Especially all these actors and everybody who comes to me, I will send basic, they will get an enhanced done and it will come something wrong and then they go to some big shot and they will say oh 1P deletion बहुत खराब है terminate करते. Then they run back to me and I do an amnio and it comes normal. So this is all these Hollywood, Bollywood people who come do enhanced NIPT. Enhanced is not enhanced, it is
money is
only.
enhanced, that's all, nothing else.
Money is enhanced.
Cost is enhanced. So when you are writing the prescription, you write into brackets basic and you counsel them beforehand and send them, then this problem is avoided. The second thing is we have to see the fetal fraction.
Oh yes.
Fetal fraction should be high, otherwise sometimes then the report may not be reliable. See that it's an NABL accredited lab, see the fetal fraction.
That's
If the
What
fetal
is the fetal
fraction,
fraction that you are looking at?
10%.
For
It is 4%, but then if it's a little higher, it's always better.
would
Some
you,
of the labs
Purnima,
claim-
talking about fetal fraction, if the fetal fraction is low, the lab usually tells you to send more blood little later. Would you do that or you will advise invasive?
Depends on the indication actually.
Because there is also a study that
Yeah.
low fetal fraction also is in a
Reflects
way
and-
marker for aneuploidy.
Aneuploidy, yeah.
It is a marker for aneuploidy and you should not think, oh, मैंने थोड़ा जल्दी कर दिया. 2 weeks later, again I'll collect blood and send. You must keep in mind, you are here to rule out aneuploidy. You are not here to validate the test. So you should then advise accordingly.
would a normal ultrasound not counter this argument?
Yeah, that's what I'm saying. If it's a 22-year-old, absolutely normal ultrasound, then maybe I would send it once. I won't send it the third time. But it depends. You have to just.
So the logical sequence would be a good ultrasound to start with, followed by a marker test.
Yes.
Then, if it throws an intermediate risk or something, then an NIPS. And, in that case, if only required, then you would go ahead with an invasive test.
Just one comment on NIPS. When we are talking about fetal fraction, yes, minimum 4% is what is required. Before that, below that, you'll have no call result. Now, when we are looking at fetal fraction, another thing we should look at is Z-score also. Z-score has to be more than +3 for any aneuploidy. Now, suppose your fetal fraction is showing 10 and Z-score is +2, that means that is not matching. If the fetal fraction is good, the Z-score has to come high for that particular aneuploidy. Then I know that there is some mismatch. This is not correlating. So that is also something we have to look at when we look at the NIPS report. That's important.
So you have a complex monogenic condition and prior history of such thing. How do we manage access for families seeking to detect rare single gene diseases, metabolic disorders, rather than the standard chromosomal aneuploidy? We are not talking about aneuploidy now. A monogenic condition or a metabolic disorder. How will you go about? Purnima.
The practical way would be to do at least carrier screening or even expanded carrier screening. Rare means there is no end to it. There can be thousands and thousands of disorders and you cannot rule out anything. So if you see certain things like, for example, spinal muscular atrophy, even asymptomatic people in our population, 1 in 40 may be a carrier. So it is possible that completely normal on both sides of the family, may not be even consanguineous, but belonging to same community perhaps, and they get married and they get a child with spinal muscular atrophy. So it's really worth it to do carrier screening in these people.
So in
Beyond that, I would not tell them go and do whole genome or something of whole exome of both, because you're going to throw up a lot of false positive and VOUS.
So there is a case example here, a carrier couple, scenario A. A couple discovers they are both carriers of sickle cell disease. The woman is currently 10 weeks pregnant. They state that they will only continue the pregnancy if the fetus is unaffected or a carrier, but not if the fetus has the disease. Is an invasive procedure justified here, given the 25% risk of reoccurrence of autosomal recessive condition? Vandana.
So this is a disorder which is autosomal recessive. Recurrence risk is going to be 25%. So no screening, it has to be an invasive test. We test for the sickle cell. If the parents have not been tested, then trio testing plus a karyotype. So if we are going to do an invasive testing for sickle cell, why not also do a karyotype test rather than later on do a screening test? So if the sickle is normal, then the karyotype also comes with it. We don't need to do another screening test later on.
So here is a point why carrier screening matters. Testing parents to see if they carry recessive genetic mutation. How important it is before doing an invasive technique.
Sir, autosomal recessive disorders usually happen in consanguineous marriage. So if I have a child who has got an autosomal recessive disorder, then it is implied that the parents are carriers for this. But it is always best to test the parents. But very rarely, if you are at a time when you think that we don't have so much of time to check the parents first, then we could do a trio testing together. But routinely, autosomal recessive disorder, parents have to be carrier. You can't have a de novo autosomal recessive disorder. Autosomal dominant, as what Bela showed one case, is possible that it is de novo. So if it is an autosomal dominant disorder, then the parents mostly will be normal unless it is a disorder where the parent is also having the same genetic disorder. So in autosomal dominant, definitely to test the parent. Autosomal recessive, if I have one child which has got compound heterozygous or heterozygous both, we will directly do CVS.
Knowing the mutation of a disease is very important before doing an invasive technique. Also, Bela mentioned in her presentation, because there are so many mutations, like for beta thalassemia, if you go to see, there are 450 mutations, but there are 5 common mutations amongst Indians, Asians. So knowing these mutations saves a lot of waste of time and money to do this. So if you know the mutation, you can target your diagnosis. Only then you should do an invasive technique like CVS. Otherwise, you are just doing a CVS and you are not doing justice to the situation.
Even the cost is less if we target the mutation. Target mutation is 3, 4, 5,000. If I am going to look for all the exomes, I am going to spend
15, those
20.
5 common mutations have to be matched, not 450 mutations. So takeaway here is that clinical guidelines support a patient's right to choose invasive testing after proper counseling and counseling. Diagnostic versus screening, always distinguish these two. One is high risk reporting and the other is yes or no reporting. And the gestational time, we have discussed this off and on because it's very important. And
what are the precise evidence-based procedural risks of CVS and amniocentesis that panels must consider when evaluating if a patient should undergo these invasive procedures? This has been done, right? So we know the risk factor involved, all of us are very familiar. Good hands, 0.5% is the highest they recommend. And this is the mosaic dilemma. This has also been tackled, I think, right? Regarding your placental mosaicism.
So, do you all want to say anything about...
A 38-year-old G2P1 undergoing CVS for an elevated NIPS risk for trisomy 18 receives a mosaic result, some having normal cells, some having trisomy 18. The ultrasound is completely normal. How do technical limitations like mosaicism complicate the definition of who deserves the benefits from CVS? Done. So this is panel highlights the CVS samples you may have. So that means NIPS can also diagnose the same placental cells, so also your CVS. Your vertical transmission, and this has been tackled in the lecture itself. So if you have infections like HIV, hepatitis B or hepatitis C, look at the viral load, bring it down, whether it's HIV or HBsAg, then only go in for testing. And this also has been tackled in the lecture, I think. And this is again the same thing. We look at the copies and then go in for the testing. And you know that the transmission is less through amniocentesis as compared to CVS. The panel recommend delaying the procedure 15 weeks. Okay, the same thing again from the point of immunoprophylaxis. Now this is yours.
The bioethical boundaries and social testing. Now there are situations where we draw a line on bioethical grounds regarding who deserves these invasive procedures? Is it ethical to grant access for non-medical reason, such as non-parenting testing or adult onset conditions? So there are conditions, a patient comes and she says, my father had so-and-so disease. I want to do a test, invasive test, and see that the baby I am carrying doesn't have this. What is your take in that? Will you just say, okay, come, I will do the test? What will you do?
See, if they say my father had Alzheimer's and I want to test for it, obviously I may get Alzheimer's tomorrow, okay? So I don't think that life is not worth living. So I think it's not ethical to test for something which is going to come very late in life.
So most clinics will not want to do this. Number one, if the testing, Vandana before that.
Yes, so for non-paternity, you have to go through court and they will order us if there is a conflict of paternity. So if they give us a authority to do the testing, it has to come through court. We get some for these paternity things, it has to come through court. What you are saying for adult onset, one gynecologist at my place had a husband had BRCA positive, and so she thought that BRCA can be there in my fetus also, and I don't want that fetus to have a BRCA positive which will have CA breast later on. Real case of a gynecologist. So we counseled in detail, then they went to Tata to find out BRCA ka kitna chances ho sakta hai. So they said there is a chance of BRCA being positive. Then she wanted to know female hai to BRCA zyada positive, male hai to kam positive. Finally, she was anxious and she wanted and she was a gynecologist. She got a CVS done and it came BRCA positive in the fetus also. Now, terminate, not terminate, female hai ki male hai, what to do? Finally, she continued the pregnancy. She's got a child, but that anxiety of that BRCA positive,
Male child or female?
Then why she did it?
So that is what sometimes too much knowledge is also very bad.
See, this situation, what is given here the patient didn't want it to test. The patient didn't want it to test, but wanted to know all about the fetus. When you do this test, and if it comes positive, naturally she is also affected. So she is also affected and she didn't want to do her test. And also the privacy of the genetic privacy of the fetus is also exposed, because what is going to happen 40, 60 years of age, we have already disclosed this situation.
Now the whole life that child has got a BRCA positive.
So, it's the privacy of that fetus which you have exposed. And that woman didn't want it to test herself. If fetus has come positive, she also is also affected. So what is the legal framework? How do you tackle this and gestational limits? Because we have countries and places with different level of medical termination of pregnancy, maybe 12 weeks, maybe 20 weeks, maybe 24 weeks and so on. So how would you, how do regional legal framework and statutory limits on the termination of pregnancy affect who receive or is offered an invasive diagnosis?
As far as legal aspect is concerned, it doesn't stop us from doing amniocentesis at any gestational age, because here we are trying to find out a diagnosis of a particular genetic condition, and we are not doing it for termination purpose. We are giving information to the parents about whatever genetic condition is there. We are not advising for termination. If at all it turns out to be something which is serious and they don't want to continue, they can go to the medical board and get approval. So law doesn't stop us from doing amniocentesis even at 34 weeks, even at 30 weeks. No, it doesn't stop us.
By and large, to overcome all this, you should time the test accordingly, so that if it is possible to do it with CVS and get all the results by 14 weeks, you should not get into all that hurdle. And if you are doing a late amniocentesis, it is fish which in 48 hours can put you on the right track for decision making and counseling, and then let the microarray or karyotype follow.
Sir, the situation you showed was mainly for late evolving anomalies, where you have to confirm whether there is a double bubble coming up at 28 weeks. You want to find out it's trisomy 21 or not.
So this
these
is
are the situations.
This is the statutory clock which you have to race with, and you can do tests. You should know that you can do a CVS and get over. You can do a fish and give a diagnosis, and then let the other test follow when you are having a patient in a situation of 22, 23 weeks pregnancy. So with this takeaway.
Just a minute. With this fish and QF-PCR, which is more sensitive, which is much better for trisomies? Among the two, both are similar?
Good, one is mechanical, another one is based
So which one is better in case patient has क्या करने का तो क्या बोलने का?
Fish
Sir,
QF is, sir.
all labs, some do fish, some do
Equally
QF.
sensitive and
Both
specific, right?
Mosaic, you can pick up on fish more than the QF PCR.
So fish is better.
Mosaics,
Okay.
In the earlier days, we used to sometimes do chordosynthesis because the culture used to be faster and you get the report faster. Now it really doesn't matter because the MTP law has become more lenient.
Please. Louder, louder. Sorry. Mike. Sorry?
Variance of unknown significance. VOUS, variance of unknown significance.
What is the significance of that VOUS in
That
molecular
is the most
testing?
confusing part of the report of
So your microarray and your whole exome, both can be benign, probably benign, VOUS, likely pathogenic. So this is the grade, like how red, yellow, green for a lights. So pathogenic and likely pathogenic are pathogenic. They are definitely going to cause the disease. And benign and likely benign are benign, which again not real. VOUS is something that the lab doesn't have any information much. So it is uncertain significance. So if it is VOUS, we need to find out whether parents have it or not and other things. So antenatally VOUS is very dangerous because you can't terminate on the basis of VOUS, and you can't say everything is good also. So that is why the first child or index child should be evaluated. Parents' carrier should be done before you do an amnio. You can't do an amnio and the parents said, I want everything in the world. So karyotype, microarray, whole exome. Then one VOUS comes up, then you don't know what to do. So that is why you have to test what the disease is there in the family, not do everything and say that I want a perfect child. So VOUS is very difficult. You will need to get your geneticists involved in that. You cannot terminate on VOUS.
You should not.
You cannot terminate on VOUS.
You need to have culture report.
If you do your own WES, you will find you will have 3-4 VOUS. You understand?
So not on
Terminate, no,
So
nothing.
after some 5 years, that VOUS can become pathogenic. If I publish that this was disorder causing this problem, then that VOUS will become pathogenic. Then it will come as, so every year the data changes and it will come into VOUS or pathogenic organ.
So friends, coming to the end of the
you
program,
should
before we
refer
sign off, from the 6th, yeah please, you want to say
You should
something?
refer to a good geneticist because they have ways to find out. They will study the whole family pedigree. They will try to find out if somebody else had similar, the phenotype which goes with this particular, and they will come to some conclusions. They are they know better about it than us. So don't just take it lightly, you refer it to a geneticist if at all it has come up in your
It's like the intermediate risk. So you have one more test to qualify or an opinion to qualify.
So for the Aam Janta OBGYNs people, have good friends with the fetal medicine expert and the genetist. Now before the 6 intellectuals sign off, please one message take home from all of them, one after the other, 20 seconds each. Take home message 20 seconds each. Time is short.
Sorry, sir, I was talking with her. Can I
Take
repeat?
home message, say hi, bye, thank you, whatever you want to say.
What is your last word?
So my last word is for just don't go randomly for an NIPS if you have an abnormal combined test. First thing, I always believe that telling the patient again going for an NIPS when you have an abnormal combined test doesn't really make sense. Rather go for an invasive test and depending on whether it is at the CVS or amnio.
Whether it's a screening test or diagnostic test, give a good time for pre-test counseling. 10 minutes good counseling for any test, then you will not have much problem later on explaining the result.
ideal situation is that there should be carrier testing before they go for pregnancy. If the patient is pregnant, it should be a good first trimester screen, nuchal and whichever one you want out of dual marker and NIPS, and a good anomaly scan.
The labs have to be good. So whatever you are doing, from which lab you are doing it, should also be correct, because the lab matters to you. Your scan should be good and the lab also.
A definite value for the test, use them judiciously, but find out what you wish to know beforehand.
I think the first test which is done should be done well, especially the NT scan, and it should be done within that period, because most of the patients, they don't realize how important it is to be done during the between 11 to 13 weeks. They either come very late. So I think that should be the test which should be done properly.
Thank you very much,
Very
all the
much,
panelists.
Big round of applause.
Big round of applause.
What a lovely panel we've had. Really,
And
so very nice.
your patient participation and interactive approach to the entire thing. Thank you very much. Thank you, President
A good
Anurag.
moderation,
And
In case of trouble, you know whom to contact.
AFG panels are always the best.
Raju, your questions are very thorough. All of them, they are completely covering everything, and I think everybody is going to remember Manohar's comment on that triple X.
Everybody
On behalf
remembers
of all
Manohar.
panelists, we are thankful. Yes, on behalf of all panelists, we are thankful to Dr. Raju and Dr. Manohar Motwani for wonderful panel.
So a big thank you to our moderators and panelists for a true AFG style panel. It was absolutely informative and insightful. Thank you so much. Dr. Unnati Shah. Madam is a senior consultant in Malad. She's a medical director of Vatsalya Hospital and a consultant at Gokuldham Medical Center in Cloud9 Hospitals. She's the past president and member of Trust Board of AFG. And Dr. Ujwala Netam, she's the director of Sun Hospital and Dr. Ujwala Fertility Center, and she's a practicing consultant since 20 years. She's a scientific secretary of AFG. We welcome you.
Good afternoon, everyone. After very nice lectures and excellent panel discussion, now I would like to invite Dr. Raju Sahitya. Dr. Raju Sahitya doesn't need any introduction to this crowd, and today he is a convener of today's program. And when there is invasive prenatal testing, then Raju Sahitya is the first name to will come in our mind. Today he is going to speak on ultrasound principles involved in invasive prenatal diagnostic techniques, and which are very important things all of us we should know. Over to you.
Can I sit down and talk then? Because they have given me this place. So I welcome you once again. Thank you for being there for the hands-on training, and on behalf of the President, Dr. Anurag Bate, and the office bearers and AFG Managing Committee, I welcome you once again to this hands-on training program, and thank you for the kind introduction. So it's all about Bela, it's all about prenatal diagnostic testing. Okay. So before getting there, it's important to understand the algorithm which is there for invasive prenatal diagnosis. In today's era, practicing obstetrics is changed, and it is changed for the better. So it starts with early pregnancy counseling and screening. So every patient, and incidentally, even the patients are well informed. They don't come just in the 6th month, 7th month of pregnancy to register to deliver. They know and they understand the importance of screening and understanding that they are at the background risk, low risk or high risk. So it starts with early pregnancy diagnosis, counseling and screening in the very first trimester. Rather, in the very first visit, you should counsel and tell them that you are lucky to be born in an era where you will know that you are carrying a healthy pregnancy. So that starts with the biochemical risk assessment, which is very standard and very good. But remember that NIPS has its role for those who are already known to be at high risk, a family history, a monogenic disorder, and if there is a previous pregnancy with an issue, then they should not be put to biochemical testing, they should be put to NIPS, because anyway this discussion will come later on that this is more sensitive. So you have to do an NIPS for such patients, otherwise biochemical risk assessment is equally, or I should say very well, and a standard way to go about. Even up to 94% accuracy it can give you, done with good hands, a good NT, and taking a good lab, the biochemical analytes, you can get a diagnosis. Naturally, those who are low risk will go through the pregnancy like a normal pregnancy, like how it should be. Then those reported high risk, they deserve invasive prenatal diagnosis, because it is very well established that this is screening and this is diagnostic, and the procedures available are the chorionic villus sampling in the first trimester and the NIPS for those who are at high risk. You do these tests. For those coming as high risk, do a CVS or amnio. CVS for first trimester, amniocentesis for those who are reported late for reasons to delay, for the reasons you understood, the mosaicism and all those factors. Chordosynthesis, fetal blood, used to be used earlier for such diagnosis, not anymore, because the skill required for that is different, and it is very, very important to be very well doing those procedures. Otherwise, it is CVS or amniocentesis. Those reported as euploid, or there is no aneuploidy, will go through the pregnancy in a normal way, like otherwise. And those who are reported confirmed aneuploidy, they will undergo a post-test counseling, which is very, very important, so that they know what to do next. So when you are reported, your pregnancy is reported at high risk, screen high risk, it is time to open your eye, and you want to visualize the chromosomes, like what, with the open eye this way, and depending on the situation, fish is very important, and you should order for fish, which gives you a diagnosis in 24 to 48 hours, definitely within 72 hours, and you know about the most common chromosome aneuploidies, that is 21, 13, 18, and the sex chromosomes. Most of the journeys there, these are the common conditions. You should never ever take a shortcut and say that I will save on not doing karyotyping. Because you may think about these 5 common chromosomes, but there could be other rare situations in chromosomes which may be affected. So you have the material, you have the tissue, you have the fetal DNA. So don't end up just with fish. You must also tell the patient how important it is to do a karyotype, and karyotype or microarray depending upon the situation. So we all know the law of the land, and the law of the land is that all this is to be done as per the PCPNDT Act. The center has to be registered as an ultrasound and a genetic clinic, and a registered medical practitioner trained and experienced in these invasive techniques should be doing these tests. Now I am coming to speak to you on the topic which I have chosen to speak, because this is very important when you will go there to the mannequin, because until now you saw all the presentations where amniocentesis was shown, a chorion biopsy was shown, a chordosynthesis was shown, and the needle going to the target as if it is so very easy. Yes, it is easy, provided you follow the ultrasound principles involved in the ultrasound guided invasive prenatal diagnostic techniques. Otherwise, you will wonder that all the videos which you saw, when you go to your patient and you're doing it, it is not so. But it can be if you follow these principles, and now pay attention to these principles. And in order to maximize success, you should know your transducer. You should have a correct transducer, a proper gain setting. You may be, actually doing it very well, but the machine, the gain is not set. You may not see the metallic needle and the needle tip. You may not. If you set the gain correctly, you will see it as a very sharp line. And of course, enough experience in the matter. And like some of the learned speakers mentioned, that it is the operator sonologist coordination. Both are hand in hand. They know the procedure and they know how to direct you. Only then you will be doing an ultrasound guided procedure. So coming to the principles proper, you have a probe, you have a target, and you have a needle. The rule is move only one. Of these 3, move only one. The remaining 2 is like static, statue, not moving. The transducer, once locates the target, has got no business to move. The target, if it is chorionebular sampling, it doesn't matter, but if it is amniocentesis, you have to have patience and see that you don't encounter important pregnancy structures. The fetus, the placenta, the umbilical cord, and the intervening other structures. Then the needle goes like a dart. It goes like a dart and reaches the target. So the probe commonly used, it's always trans-abdominal sonography in these cases. At times in some workshops, I've been asked whether it is a trans-TVS probe. No. Whether you are doing a trans-cervical or a trans-abdominal, both has a convex probe and a curvilinear of 3.5 megahertz. You should take the advantage of this convex probe because it has got both principles. The linear array principle which used to be there earlier, and also the sector principle which used to be there. It's a combination when you have a convex probe. Always apply the probe very gently because it's it's a curved contour of a pregnant uterus with the bladder full and all. If you are going to apply pressure, you are not only going to give pain and discomfort to a painless procedure of CVS and make it painful, you are also going to mislead your own guidance, because this abdomen is gelled when you do a transabdominal sonography, and if you are going to apply pressure, you are going to glide away. And what was shown to you by the ultrasound beam is no longer visible. So probe moves and evaluates. The business of probe is there only to just guide you. Then it stabilizes and it guides the needle to the target. For this being always seen on the ultrasound machine, you should know the ultrasound beam. Usually we consider the thickness of the probe. The thickness of the probe is all that what sees. No, it is just a millimeter or millimeter and a half thick, fanning out like a Japanese fan in the middle of the transducer. And you have a marker on the transducer on either side like this. It is just the thickness of that. So just imagine you have to align your needle or cannula in this thin blade like ultrasound beam. You are not just aligning to the ultrasound transducer. It is the beam. If you are in the beam, you will see it all from the entry point, the shaft and the tip. Target, of course, you will have always go for path which is free of important structures, and if in amniocentesis you find that fetus is moved, you have to have patience, you have to wait, you have to reorient. In case the good pocket which was there is filled up with the head of the fetus or abdomen of the fetus, you have to just hold. You may have to withdraw the needle and make another entry. And the needle or the cannula, these are hyperechoic brilliant images because they are metal and the gain setting makes it so. Penetrates and proceeds to the target. Like I said, the probe static, just guiding, and you have to visualize the entire needle at all times. So this is the cannula which is shown up, and this is the transcervical CVS cannula. It is very economical, reusable, easy autoclavable, and the best part, it is malleable. You can change it to shape the way you want. You can have it straight, you can have it just a gentle curve, you can have a C shape absolutely, depending upon the location of your target. And the transabdominal CVS, these are disposable needle. It can be the normal size spinal needle, or depending upon the health of the patient, it can be a long needle. That you have to decide before the procedure and before you hold the needle in your hand. Because you will measure with your cursor the depth. If your spinal needle is about 6 inches or so and the depth is 8 inches, you will be just imagining to be there. So you have to choose the needle accordingly, and you have to have longer needles for healthier patients. And of course, visualizing the needle all the way from the entry point towards the target, reaching the target, and not only that, even when you exit, you should do it under vision so that you don't cause a scratch on the important product of conceptions. Now the challenge is what you face. It is not always that the patient is lying and you are there and you are going to go from the top, from the surface down. The location of the target is very important. It could be in the center, it could be on the side, it could be far like this. Accordingly, the approach to the technique will be anterior, lateral, posterior. Always vital structure in the path are to be kept in mind and avoided. So therefore, even if the sonography has been done, few hours earlier or one day before, just before the procedure, the GPS of the procedure is very important because it may have changed. what was in a good anterior pocket, you will find a fetal head just bouncing over there. You may have to take a lateral approach. I spoke about the beam, how thin it is and how important it is to align your needle in the ultrasound beam. So needle is inserted in the same plane as the ultrasound beam. I cannot overemphasize this because otherwise you are not going to see what you should be seeing. Needle visible as a bright line, and optimal gain setting does it. Many a times I have seen that I think I am there at the tip is in the pocket, but I am not seeing the needle. Only if I will tell Ankesh, just increase the gain. He'll be standing there with the ultrasound machine and I am going to see it so very brilliantly. And the needle should be advanced and very important in a convex probe that it should be at 45 degrees. I'll explain to you. We see with our eye, but actually we are seeing at the pupil, not at the entire eyeball. We are seeing through the pupil. So it is as thin as that pupillary entry. If I have to keep a needle here, I may vaguely see it or not see it. But if I keep it at 45 degrees, I will see if I don't want to see it also. So that 45 degrees is very important, like what you are seeing here. Now this is an image which is showing you the freehand approach, but the two are different. One is in plane. You are in the beam. You are 45 degrees or less than 45 degrees. Only then you will see the entire needle, the entry point, the shaft and the tip. But just imagine if you are out of the plane, like what you are seeing in the second image. The point which you are seeing in the ultrasound, it's not the tip, it is the transection of that needle. The tip may be far away, already done damage. And you think that still you have to go inside because that you are seeing the transection of the needle. And in the first image, you know your limitations and you know your accuracy. So this is the alignment we are talking about. And when you do this, this is how you are going to see. If this transducer has to even turn side to side, you will get a transection of the needle and not the tip of the needle. So at times, it can happen that you did something and the transducer glided, and suddenly when the syringe is attached to the needle, you see that you are not able to see the needle. It is lost. You must leave the needle alone because that is the weapon you have put there in the pregnancy. It's a weapon. That same needle, which is a diagnostic needle, becomes a weapon. You leave it there and then you start the search. Locate the needle by angulating the probe. Move probe and identify the needle tip, which is most crucial. And then you bring it together under your control and bring it back at the target. You may do all these maneuvers. You may from 45 degrees move to 90 degrees till you are going to get this alignment done. Only then the needle has to be advanced. Otherwise, needle hasn't to be advanced. It has to just remain there. So, align your mind with the procedure. The operator's skill in aligning the probe and the needle is the most important variable, influencing the needle visualization. The same image down. It's not necessary you are making a circle around the sun. It depends from where the camera has been kept to take this picture. And it makes you feel that as if you are holding the sun in your ring of the fingers. Now very important is the depth. Very important is the depth. Everything said and done, you know what to do and you know the 45 degrees, you know the ultrasound beam, but how deep to go? And what should you do for that depth? So you have to estimate the depth because finally the tip of the needle has to go there. So angle remains 45 degrees. Now, if this is the situation and This is the center of the probe, and this is the depth what you have measured. Suppose it is 8 centimeters. You have to take from the center of this transducer, measure 8 centimeters away. And then at 45 degrees, you will hit the target without a millimeter difference. So, if you have done that, there it goes like a dart. Otherwise, it will go 1 centimeter above or 1 centimeter below. So, you come to know the point of entry from the transducer. You are going to take the center, you are going to measure this 8 centimeters, 45 degrees and hit down. 45 degrees and hit down in the beam, and then you are at, like Arjuna. You become Arjuna and you hit the eye of the fish. And if it is shallow, same thing, closer to the transducer, and there it goes. So training for invasive procedures should begin on mannequin simulator, which you are going to witness and experience, and to practice the maintenance of needle path within the ultrasound window so that the entire needle remains visible at all times. You are not going to compromise that you saw the entry point, you saw the tip, the shaft also has to be seen, and then you will enjoy the procedure and you will sleep well because you know that you have not intervened any important structures. So these are the mannequins which you have here for transabdominal and transcervical, and this is how for the students, you know, we have this mannequin and training going on. Should we straight go to the mannequin, because this is a 6 minutes video telling you how to do the mannequin.
You can show.
Straight to the mannequin. Okay. Straight to the, because now we are running time. So procedures you have seen, there was another video of 5 minutes showing all the procedures, and our learned speakers, you know, Vandana, Purnima, Bela have shown enough procedures. So thank you very much. So these are the ultrasound principles which you heard, you are going to see and practice over there, practice again and again, so that you eagerly wait for a patient to come for invasive prenatal diagnosis and you can do it. Thank you very much.
Thank you so much, Raju Sahitya sir. Without this 20 minutes of what you have said, it would have been difficult. And that's why you are a teacher and you conduct so many beautiful workshops.
So we are talking about doing these procedures, and this is a specially designed mannequin simulator, simulating with ovoid of the uterus with pregnancy. So there is a placenta, there is a fluid, and there is fetus and umbilical cord inside this. So you have to game check.
Second bench.
अरे वंदना है ना वहाँ सेकंड में वंदना carry over. अरे you know Vandana is my always companion in this. So see this. So that's the umbilical cord. And that is the amniotic fluid pocket, and this is the fetus. So as if you are with the patient. Vandana, please take over the other one. Yeah. How many are there? Give it to Vandana.
So what? ये देखना है ना स्क्रीन. अच्छा स्क्रीन तो देखो.
Amniotic fluid pocket. They are experts. We have gone places together. Name it. Varanasi and so many places. Gujarat, Ahmedabad, everywhere. Then you have a clue from here that this is the entry point. And then after that it is like you will say, चलो अभी घर जाते हैं मेरे को आ गया. Okay. Now reduce the gain. Gain थोड़ा reduce करो. थोड़ा gain reduce करो. Fluid जैसा दिखना चाहिए. Now I keep it here and I go 45 degrees. See, this is the plane. I'll explain the plane once again. Plane. So this thickness is the ultrasound beam, not all this. This one, from here to here. So you have to know that if you are going to keep the transducer, and we have seen some people doing it and doing all this, you may get into the pocket, but it was not the way it should have been done. Not in the way it should have. Not ultrasound principle is not followed. Even here, if I dip, something will happen. But no, you don't know what intervening structures are there. So when you do this, and you are here, and now when I go down there, you will see the needle. देखा कितना easy है? You saw that? You saw this? Yeah. So even if I don't see there, I am going to tell you when it is going to be visible. Did you see it?
Yes.
Why? Why I could tell you? Because I know that I was in the beam, I was in the plane. So always when you begin the procedure, don't look there. Why? Because you have to perfect your 45 degrees at the beam. So पहले ध्यान इधर, and then उधर जाओ.
And 45 degrees. So if I come directly in the center and I go 45, see there what it is. So I don't even have to. No, you will see the whole. This is a artificial, this is the one needle. One thing I will not mention is if I do it like this, then I will not see the whole.
Suppose you have seen percent, because you may reach little further than what you are thinking. So 3 centimeters away. Also, if it's a posterior placenta, what happens is, especially when you press this, that comes very close to it. So it can happen that when you're going in, you can just hit a chorionic plate vessel on the posterior side also. So that pocket has to be good. When you press, because whenever when you're learning driving, you hold this steering like that. When you're doing this, you tend to press without realizing, and you're displacing the shield out. So be careful. Excessive pressure, you out. So then, you suppose that the posterior placenta, also the central part is very thick, it's coming more in front. You may want to go a little where there's more distance.
So I'm going here.
Because if you pierce that
Typical one line
If I want to go very low down, I'm going here. So the angle change. So one method is this. The other method is if I am very close, rather than that I am very close, I can do them also. This is actually
find something like that. See, they say that you should. I feel comfortable. Holding this in my right hand. Because as surgeons, we are used to using our left hand. Textbook don't say other way around. You can if you are worried or patient is very anxious. It's not really required because our needle also is thin. But I know what you mean. Sometimes when you're given that, then you are more relaxed. At least when you're entering the skin, the patient will not get it. And bladder.
थैंक यू वंदना
TVS हम दिखा रहे हैं
दिखा रहे ना एक है
प्लेसेंटा बोला
नो नो नॉट TVS ट्रांस सर्वाइकल CVS
सर्वाइकल
yeah see you know stabilize this वंदना
this has to be so now 45 ऐसे लगता है कि इसको मैं ऐसे करूँगी तो दिखेगा इसको जब सिर्फ इसके लेवल पे होगा तभी दिखेगा moving there to right doesn't mean moving needle to right because अपने माइंड में होता है वो राइट का करना है मुझे और यहाँ राइट has to just be in the same am I right now
super
so you are now
so you know what you have to do Nilima first you have to do your pop fluid pop then don't look there you have to
8 centimeters.
8 centimeters depth ka hai. Not here.
Not the distance, no?
So here, then you have to, this is the plane. This is the beam. This marker is the beam. And then you have to be here and 45 degrees down the finger. You have to see the needle. You have to see.
freeze कर
Oh, freeze there.
नहीं
कैंसिल अगेन
कैंसिल
उसको टच करना
Touch screen. So you know what? You have to see the entry point. You are getting the entry point. You have got that in your hand. And then you do this and see. See, you saw that? You saw. So if you have done this correct, no, there is no need to bother. So पहले क्या है ना, when you are starting, don't look there. You just find the pocket and then you see and then मेरा एक्चुअली रॉन्ग हैंड यूज़ करता हूँ मैं राइट हैंड मैं लेफ्ट हैंड से कर रहा हूँ अभी एंड व्हेन यू डू दिस
No, they have micro
you have to see it. The needle doesn't have a choice. See, if you are going to show the beam is obliged to show you the needle.
Correct. So what is the importance of
सर है उसके
ये तो
लाइट चालू करने के आ रहा है
अरे चलेगा
अब काला फुट रहेगा सर एक मिनट
काला कुत्ता
हाँ फोटो अच्छा है अभी तक लाइट है ना मैडम अच्छा है यस या वन मोर यस ओके सर रेडी मैडम थोड़े से
थोड़ा ऐसे
हाँ थोड़ी यस यस या रेडी नाइस वन मोर